Good day, and welcome to the first part of the series of hemodynamics, the right and left ventricle working together. Now that you've completed the first series of cardiac dynamics and electrophysiology, it's time to put it to the test for the bedside evaluation of patients hemodynamically. So, one of the things we always think about in principles of hemodynamics is that we have two different groups of pressures. First of all, arterial pressure, which is the response of the arteries to the amount of volume ejected into them. And that's what, of course, gives us our systolic arterial pressure. And then the continuous column of pressure that drives perfusion, which is the diastolic pressure, and the average between the two, which is the mean. We can measure arterial pressure in the systemic arteries as well as in the pulmonary arteries. Second to that would be venous pressure. Venous pressure is the amount of pressure generated in the compliant venovascular bed in relationship to the volume that finds itself in there. So when we talk about venous pressure, we talk about the pressure of the column of blood as it ultimately fills the ventricle. And we talk about pulmonary venous pressure, and we talk about systemic venous pressure, both of which are incredibly important to us. Next, we think about blood flow. And the best way for us to monitor blood flow is to actually do a transesophageal echocardiogram, or perhaps a transthoracic echocardiogram. But the way in which we best evaluate at the bedside the continuous amount of volume ejected into the arteries constituting blood flow would be to measure the stroke volume in the systemic arterial bed, and the stroke volume is the amount of volume ejected per beat. But we can also measure cardiac output in the pulmonary arterial bed, which is the amount of volume ejected per beat times 1 minute. That is, stroke volume times heart rate equals cardiac output. Now, cardiac output is a focus we take a lot when we're talking about the dynamics of the heart, the amount of volume that the patient has, and their vascular tonal quality, because that's what allows us to understand blood flow. And at the bedside, in a critical care unit, you most often are going to be looking at stroke volume in the arterial vasculature, utilizing a flow track and an EV1000, and that stroke volume times heart rate will calculate your cardiac output. Now, the end result of both the arterial pressure, the venous pressure, the stroke volume, and/or the cardiac output is the delivery of blood to the tissues, and that is tissue oxygenation. The left heart actually propagates and ejects a volume that drives blood flow to the systemic tissues, to the cellular tissues. And we best evaluate basic arterial oxygen, the oxygen present in the systemic arterial bed, as SaO2. Our right heart ejects volume into the lungs, and because it ejects volume into the lungs, this is where oxygenation, of course, occurs. And so we talk about the right heart propagation of volume into the pulmonary bed. And the volume that the right heart propagates is primarily a relatively deoxygenated blood flow. Now, that deoxygenated blood flow is commonly known as SVO2 or SCVO2. And a lot more about that a little bit later. So what we want to think about in principles of hemodynamics evaluation, how much pressure is generated when volume fills the ventricle, either the left ventricle or the right ventricle, how much blood flow is powered by the left ventricle and the right ventricle. Blood flow powered by the left ventricle is measured in the arterial bed as stroke volume, and blood flow propelled by the right ventricle is measured in the pulmonary artery, and it's measured as cardiac output, which is stroke volume times heart rate. And then we look at oxygenation, how much oxygen delivers to our cells and how much oxygen is returned to the right heart, SaO2 and SVO2 respectively. So, we think about our right heart and our left heart, and although they have an incredibly intimate relationship, they are different. The right heart is the conduit of blood flow into the lungs, and that blood that fills the right ventricle is primarily deoxygenated, and it fills primarily from the central veins. Central veins, right atria, right ventricle. This is a constant flow of blood into the right ventricle by the actual venous pressure column. And that is so incredibly important because when we see failure of the right ventricle, what we will typically see is systemic venous congestion. Now, the right ventricle ejects blood up into the pulmonary vault with really two primary purposes: to move blood past the alveoli and remove carbon dioxide and also take up oxygen. Now, the pulmonary bed is a very low resistant bed. The right ventricle is a very weak muscle indeed, because it's not necessary to propagate a tremendous amount of pressure to push blood up into the pulmonary vault. Now, that's in the normal situation, and of course, our critically ill patients find themselves in an extraordinarily abnormal situation. Now, the contraction of the right ventricle moves the filling volume against the resistance of the pulmonary vault, and that contractility is an inherent property of the myocardium that is, yes indeed, stimulated by depolarization and the freeing of calcium, which allows the muscle to contract. So we always want to maintain adequate volume, adequate filling pressure, and adequate contractility in order to mobilize blood into the pulmonary vault. Now, when we look at the left heart, those basic premises are exactly the same, but the left heart is actually a muscular mobilizer. It's not just a conduit. It has to generate a high degree of pressure to open the aortic valve and bolus blood out into the aorta and the systemic artery. Now, the left ventricle fills with reoxygenated blood coming from alveolar capillary interface through the pulmonary venules to the pulmonary veins to the left atria and into the left ventricle. That pressure column actually tells us about the volume that's transferring into the ventricle and the compliance of the ventricle that is being filled. Now, that's incredibly important. The left ventricle boluses blood or ejects blood into the systemic vault, which is an area of extraordinarily high resistance because of the longer arteries and the longer arterioles and the short capillary surface. Now, the goal of the left heart is to deliver oxygen to the cells and to uptake carbon dioxide. So to remove respiratory and metabolic waste and deliver oxygen to the tissues. And it does that, of course, through its viable contraction. Now remember, contraction cannot happen without depolarization. And when depolarization is abnormal, too slow, too fast, an abnormal foci, we're going to interrupt our actual ejection volume. So that's so important in terms of understanding dysrhythmias and the effect on the mechanical component of the heart, which then in turn affects the filling of the ventricle and therefore the ejection from the ventricle. Now, the left ventricle is contracting against a very high resistance system, and that high resistance system is actually defined by vascular tonal qualities that can redirect blood flow away from certain areas, those areas known as non-essential, meaning that cellular groups within the human body have a very low requirement for oxygen. So the vascular tonal quality in the systemic artery is so incredibly important because you have an increased vasoconstriction to shift blood away from non-essential, which are low oxygen requiring organs, to high essential, which are highly oxygen dependent organs, like the brain and the heart. And that's why we see the evolution of dysrhythmias or the change in level of consciousness as a very significant subjective hemodynamic qualifier. Very important to us when we're thinking about how our patients are doing and how we evaluate them subjectively at the bedside for hemodynamic qualities. Now, those basic concepts, again, which I think are just incredibly and profoundly important. Basic concepts are the pressure column of ventricular filling. Now, during ventricular diastole, which is not the same as what we talk about in the arteries, ventricular diastole is when the ventricular chambers are relaxed and they are ultimately filling with volume. The compliance of diastole actually determines how well your ventricles are going to fill with volume. So this is profoundly important when we're considering how to optimize filling and therefore ejection from our ventricles. We talk about right ventricular filling pressure. That's the column of volume in a compliant or non-compliant chamber. So the more compliant the right ventricle, the lower the pressure will be. The less compliant the right ventricle, the higher the pressure will be. Volume actually affects this pressure column very little. It is primarily affected by the compliance or loss of compliance from the ventricle. The right ventricle fills from our systemic veins into the right atria, which ultimately fills the right ventricle. So we can look at right atrial pressure, which we can do with a pulmonary arterial catheter, or central venous pressure, which we can do with a central venous catheter. And we look at that pressure as an indicator of the pressure column of filling the ventricle, and that is most profoundly affected by changes in ventricular compliance. Now we call that central venous pressure. Now the right ventricle is filling from the right atria from the systemic veins, and the systemic veins are primarily carrying relatively deoxygenated blood, because the veins carrying blood back to the heart are carrying blood that has also already been exposed through capillaries to the cells, and cells have taken the oxygen. So we talk about this as a relatively deoxygenated state, and if we make a measure from a central venous blood gas, what we can see is how much oxygen our cells used overall. That's actually measured as SVO2, and we measure that from a central venous blood gas or from the tip of our pulmonary arterial catheter. Now our left ventricle is primarily filling with oxygenated blood. That capillaries exposed to the alveolus actually promote oxygen uptake into the blood and CO2 download from the blood to the alveolus and out into the atmosphere. Oxygenated blood then mobilizes through the pulmonary venules, pulmonary veins, to the left atria, and ultimately to the left ventricle. So yet again, we want to remind ourselves that during relaxation of the ventricles have very little resistance, and volume should flood into the ventricle. And the pressure is primarily reflective of the compliance of the ventricle. Now, we talk about two basic measures here, both of which will be highly unlikely for any of you to see because of the kinds of patients you'll be taking care of. But we're still going to reflect it subjectively by some of our other criteria. But volume in the veins that transfers to the left ventricle ultimately, volume in the veins exerts, of course, a pressure column. That pressure column can be measured in the left atria by a left atrial line, which we do not use here at Grady, or by a PA catheter with a tip on the tip of the catheter having a balloon that gets inflated and the catheter migrates forward, looking at the constant pressure of the column of volume in pulmonary veins, pulmonary venules, left atria, and ultimately left ventricle. That's known as your pulmonary capillary wedge pressure and indirectly reflected as your pulmonary artery diastolic pressure. So that's ventricular filling, the measurement of the pressure in the veins that have an ultimate responsibility for filling the ventricle. Right-sided filling pressure, CVP, left-sided pressure, pulmonary capillary wedge pressure, or PAD. Now, in order to optimize ejection, you must have an optimized filling. But now let's think about ventricular ejection. The ventricles eject blood into the arteries that leave them. For the right heart, the artery leaving the right ventricle would be the pulmonary artery. Now that pulmonary artery, despite its name, artery, is going away from the heart but is carrying deoxygenated blood. So when we look at right ventricular ejection, we actually look at a mechanism of temperature change over time. That's called the cardiac output measure we make in the pulmonary artery. So we can look at right ventricular function by looking at cardiac output as measured in the pulmonary artery. Requires a pulmonary arterial catheter. We also can look at pulmonary artery systolic pressure as a representation of right ventricular ejection. And both of those, the pulmonary artery cardiac output and the pulmonary artery systolic pressure, are representative of right ventricular ejection. For the left heart is ejecting oxygenated blood to be delivered to the tissues. And we have many ways we can look at this. We can evaluate your ejection fraction with an echocardiogram. We can look at left ventricular stroke volume in the systemic arterial component using an A-line and a specialized transducer known as FlowTrack. That's the transducer, and connected to a monitor known as the EV1000. That allows us to evaluate left ventricular ejection. But we also can look at that as a basic systolic pressure in the systemic artery, which is reflecting left ventricular ejection. So we think about that whole cardiac cycle and how the atria and ventricles fill and therefore eject. We call that the diastole of the chamber and the systolic pressure gradient of the chamber. So clinical correlates for us, let's remember, venous pressure means that it's atrial and ventricular filling and compliance related to filling from the veins. So we talk about central venous pressure as a reflection of the right ventricular filling, and normal CVP is 4 to 8 millimeters of mercury. If I have a patient who is spontaneously breathing, that negative pressure in the thorax actually will drop their central venous pressure because the negative pressure in the thorax dilates the ventricles and dilates the veins and arteries. So what we can see is that pressure reduces when the patient is taking only a spontaneous breath. When we look at the filling of our left ventricle, we think about the pulmonary capillary wedge pressure, or the PAD. Pulmonary capillary wedge pressure and PAD are both close to 8 to 12 millimeters of mercury, which reflects the pressure column of LV filling. Now, we don't have any lines in our patient. So one of the things we look at is we look at right ventricular optimization and filling by looking at your neck veins, by looking at your body weight. We think about left ventricular optimization filling by looking at your chest x-ray and looking at your gas exchange, which would be at the bedside your SpO2. As the lungs get more fluid extravasating into the interstitial bed, the chest x-ray will look worse and our patient's pulse ox will drop. So we're going to use those clinical correlates for the filling evaluation from the veins. Then we think about ventricular and arterial systolic pressure, which is the ejection from the ventricle into the artery. Now, we really like to talk a lot about right ventricular ejection, but the only way we can really see right ventricular ejection gradients and pulmonary pressure is with a pulmonary arterial catheter or an echocardiogram or a right heart catheter, pulmonary artery, in the cath lab. Otherwise, we're not going to be able to see that pressure. But the normal right ventricular ejection pressure, meaning the systolic pressure in the pulmonary artery, is normally 20 to 30 millimeters of mercury. Unlike what we can evaluate with left ventricular ejection, the left ventricle ejects into the systemic artery and normally generates a pressure of 80 to 120 millimeters of mercury. So I can evaluate LV ejection quite simply by looking at your systemic arterial pressure. But I need to be able to do that continuously, not intermittently, because that's a photo in the video of ventricular functions. Not very helpful. As we know, photos don't tell us nearly the story a video does. So continuous monitoring of systemic arterial pressure gives us a continuous evaluation tool for LV ejection. So very, very important when we're evaluating and caring for our patients. Arterial diastolic pressure. Now, diastolic pressure in the artery, remember, is different than diastolic pressure in the ventricle. Diastolic pressure in the artery is a reflection of the tone of our arteries, meaning if the artery is dilated, the diastolic pressure will be lower, and if the artery is constricted, the diastolic pressure will be higher. So really what we think about is arterial diastolic pressure as a reflection of the pressure of vascular tone. And that's the one that so significantly maintains and assists with perfusion. And that's because the MAP is a simple calculation between systolic pressure and diastolic pressure, most affected by diastolic pressure. Now, if we think about pulmonary vascular tone and pulmonary artery diastolic pressure, normal pulmonary artery diastolic pressure is 8 to 15 millimeters of mercury. And normal systemic arterial diastolic pressure is 60 to 80 millimeters of mercury. So that's a really important perspective. But something else you might not be thinking about, which is going to be coming up in just a minute, is that the actual arterial diastolic pressure is what drives the volume past the capillaries and pushes the venous column of blood forward so we fill our ventricles. So everything is connected. Everything is essential. We can't understand just one thing. We have to understand everything to make the right decisions at the bedside. Now, if I wanted to measure pressures in different chambers, the 3 chambers I'm going to talk about here is one you hope you never measure unless you're in the cath lab, and that would be intraventricular pressure, measuring the pressure in the ventricle itself. Now, the diastolic pressure in the ventricle goes very close to 0, and 0 means 0 in relationship to atmospheric pressure. That's what we talk about when we talk about 0 when we're looking at pressure monitoring. 0 equals atmospheric pressure. So we live here in Georgia. Our atmospheric pressure is somewhere around 748. 748 millimeters of mercury, which we call 0. And any pressure that the patient generates above 0 is what we measure as their pressure. But patients can also have pressures less than 0 in certain chambers. One of those chambers is intraventricular. The intraventricular pressure measures the systolic pressure that is required to open the valve leaving the ventricle and bolus blood out into the artery. The diastolic pressure represents the complete relaxation of the ventricle with very little volume inside. So oftentimes, intraventricular, both right and left, diastolic pressures in the ventricle are close to 0. Arterial pressure is that response to the active ejection of blood from the ventricles, looking at pulmonary artery pressure and systemic artery pressure, the combination of the response of the artery to a ventricular ejection, and then the constancy of blood flow through the vessel, which is our diastolic pressure. So arterial pressure has a peak and a fall, and in between the peak, always takes me a second, the peak and the fall, the peak and the fall will be the closure of the valve separating the ventricle from the artery. That means the pulmonic valve on the right, and the arterial, the aortic valve on the left. Pulmonic on the right, aortic on the left. That instills a transition between systole and diastole, and that is known as the dicrotic notch. The dicrotic notch is the transient drop and then increase in pressure when the valve that separates the ventricle from the artery closes. Now, why that's so important is because that's what uniquely identifies arterial pressure from ventricular pressure. In ventricular pressure, all you see is the ventricle goes, whoa, whoa, squeezing that blood and ejecting it forward and then relaxing. So a big push to get it out, and then a big drive to relax. Big push to get it out, and then a drive to relax. Systole, diastole. And that's intraventricular. But there also is pressure measured in the artery that's very similar. The big response of the artery when the ventricle boluses blood out, and then the fall to the continuous arterial tone. That's why diastolic pressure in the artery does not mimic diastolic pressure in the ventricle. Systolic pressure in the artery mimics systolic pressure in the ventricle because they are basically about one and the same. Diastolic pressure, though, is very, very different. Because we have arteriolar tone and because our ventricles were designed to be very compliant, ventricular diastolic pressure is close to zero. Arterial diastolic pressure is not close to zero. It's a constant relationship of volume in a vessel that may be dilated or constricted. So the volume through that vessel related to whether the vessel is constricted, higher pressure, or dilated, lower pressure. And then, of course, is our venous pressure. And venous pressure and arterial pressure are the things we're most constant with whenever we take a look at pressure monitoring in our critically ill patients. So important for us to appreciate and understand. Venous pressure primarily reflects the pressure required to fill the ventricle. It's measured in the veins and it's not pulsatile. It doesn't have a big systolic component and a differentiation to diastole. It's just a transient pressure change related to the contraction of the atria, because that reflects in the vein, the closure in the AV valve, because that reflects in the vein, and the valvular bulge up into the atria when the ventricle ejects. So, contraction, closure, bulge. Contraction, closure, bulge. These are called, if you look at the picture of the venous pressure on number 3, the A wave, atrial contraction, the C wave, closure of the AV valve, and the V wave, valvular bulge up into the atria on ventricular contraction. Now, of course, the C wave and V wave, and therefore the A wave as well, are profoundly affected when there's valvular disintegrity. But that's a little beyond what we need to express and understand in today's lesson on basic hemodynamics. So let's just remember, when we're talking about cardiac hemodynamics, what we're looking at is intraventricular pressure, which you will not see unless you have a PA catheter, unless you're in the cath lab, or you will summarize that with an echocardiogram. Arterial pressure, which you measure both in the systemic artery and the pulmonary artery. Systemic arterial pressure means something we measure all the time, looking at systole as a reflection of LV ejection and diastole as a reflection of arterial tone. And then venous pressure, which we actually look at all the time, looking at the objective data of venous pressure for the right heart in the central venous catheter and the objective data for the left heart using a PA catheter. And then the subjective data of the right ventricle and the pressure required to fill the right ventricle by looking at neck vein distension and systemic edema. And for filling of the left ventricle, evaluation of our pulmonary veins, looking at pulmonary edema and SpO2. As pulmonary edema increases, SpO2 comes down. So it's a very simple trade-off in terms of how we evaluate our patients. Okay, now most of us think the right and left heart are intimately related and they do everything together. They are never divorced. Well, that isn't true. Of course, that's not true. And even in a good marital intimate relationship between the right ventricle and the left ventricle actually is a much bigger muscle, much higher contractility, and has an ejection of 60% of the volume that fills it. That's what we call the ejection fraction. The amount of volume ejected divided by the amount of volume that fills the ventricle. That is our ejection fraction. The left ventricle has a normal ejection fraction of 50 to 75% with an average of around 60%. The right ventricle has a much lower ejection fraction because it's not a very big muscle. It has to have a lot of volume in it in order to coordinate that as an ejection into the pulmonary artery. And the right ventricle ejects about 40% of the volume that fills it. So again, stroke volume divided by end diastolic volume. So volume ejected divided by volume filling. The right ventricle in a normal environment has an ejection fraction of about 40%. So left ventricle ejects around 60%. It's a big old muscle. The right ventricle ejects about 40%. It's a weak little muscle. It's kind of the difference between Arnold Schwarzenegger and Pee Wee Herman, if you know who either of those are, because you're all really young. You might not know that, but that's the real relationship. To remind ourselves, LV is muscular, RV is much weaker. And we have to consider that whenever there's changes in the requirement for ventricular contraction. So, always important to remember that the right and left heart have a responsibility, and that is the delivery of blood that is transporting hemoglobin with maximal saturation from the left heart and minimal saturation from the right heart. Right heart is delivering blood into the alveolar capillary exchange network in order to optimize oxygen uptake into the blood and CO2 downloaded into the alveoli. The left heart is mobilizing blood flow in order to optimize oxygen delivery to the cell and removal of metabolic and respiratory waste products. So incredibly important in terms of how we look at right and left ventricular function. So let's think about what's shared in this intimate marriage of the right and left ventricle. What is shared? Because if you don't understand what's shared, then you don't understand what uncouples and what kinds of things affect more significantly one ventricle versus the other. Okay, so what is shared? The right and left ventricle share a mobile intraventricular septum. That's the wall that divides the right and left heart, and you can see it plainly in this little cartoon. In this, oh, I can't get my hands right. I don't know. You can figure it out. This little cartoon where you've got a septum that divides right and left heart. Now, normally that septum actually deviates a bit towards the right, but what we also can see is that when we have a very big right ventricle, the septum will deviate towards the left. And that's not normal because it changes the left ventricular diameter and therefore the left ventricular compliance. So we always like to look at that septal wall on echocardiogram to see which direction the bow goes when the ventricles are filling and contracting. What's also important that is interdependent between the right ventricle and the left ventricle is that the ventricle itself is encased in a rigid pericardial sac. Now, when I say rigid, I mean relatively rigid, right? If I'm adding fluid into the pericardial sac over time, what will happen is the sac will distend outwards. But if I do it acutely, so I have a bleed into the pericardial sac, what will happen is compression will go inwards. So it's really important to remember the role of that sac is to keep the heart suspended and to keep it a normal size. That sac is stretchable over time, but when we acutely create changes, what will happen is the sac will pull tight against both ventricles. So that's a really critical piece of understanding interdependence. And shared circulation. Pulmonary circulation from right heart to left heart. Right heart ejects into the pulmonary circulation, left heart fills from the pulmonary circulation. Left heart ejects into the systemic circulation, and the systemic circulation fills the right heart. So whatever the right heart does, it will ultimately mobilize towards filling of the left heart. Whatever the left heart does, it will ultimately mobilize filling into the right heart. That's why they're interdependent. That's why you can't separate them fully and try to understand them only as individual ventricles, because whatever happens to one will ultimately affect the other. Okay, so again, taking a look at that septal wall, just reminding ourselves this is really during systole. As the left ventricle is contracting, the septal shifts over into the right ventricle. That allows that left ventricle to fill effectively and contract effectively. So this is the normal septal shift that we see when we look at an echocardiogram in a normal, healthy heart. That's septal wall shifting. And remember, again, that all four chambers are inside a big, nice, tight, fibrous sac. It's a double-walled sac. The outside is fibrous like the dura, And the inside of the sac, so this will be my inside of the sac, is actually vascular. And the space in between is usually filled with lymphatic fluids, and there's a lot of communication between that lymph fluid and the vascular surface. That vascular surface is known as the epicardium. So that deep two-layered pericardial sac. The parietal pericardial is the outside. The visceral pericardium is the inside, also known as the epicardium. And they are separated by the fluid that fills the pericardial cavity. So very important to remind ourselves, the role of the pericardial sac is to protect and anchor the heart. Prevent the heart from overfilling with blood because it will eventually reach the point that it can no longer fill, and also allows the heart to work in a friction-free environment. That pericardial fluid is designed to keep the heart friction-free during filling and ejection. Okay, and last but my favorite component is shared circulations. So when we're sharing circulations, what's incredibly important to remember, from cell to alveoli is the right-sided circulation, and it's deoxygenated. And as you see here, from the cell to the central vein, to the right atria, to the right ventricle, and the right ventricle up into the PA, and actually driving blood into the pulmonary vasculature at the capillary level, where the gas exchange takes place at the alveoli. So from cell, post-cell, to pre-alveoli, that's a right-sided circulation. Post-alveoli to pre-cell, that's a left-sided circulation. It is reoxygenated and hopefully oxygen-rich in order to deliver appropriate oxygen at the cellular level. From pulmonary capillaries to pulmonary venules to pulmonary vein to LA to LV and out into the systemic artery, driving blood flow dynamic through the capillaries in order to deliver oxygen to the cells. So remember, right heart ejects and left heart fills, pulmonic circulation. Left heart ejects and right heart fills, systemic circulation. But then we also think about LV pulmonary circulation and LV systemic arterial circulation and RV central venous circulation to RV pulmonary arterial circulation. It's a wonderful world, right? It is an incredible thing, all about blood flow and oxygenation, and it's what actually is the lifeblood for your patient in order for him to survive. Now let's talk about what's different from the right heart and the left heart. The left heart is a big muscle and it does a lot of work, so it uses a lot of oxygen from that essential blood flow through the coronary arteries. Primarily, the left ventricular muscle mass, when in contraction, is contracting the coronary capillaries that are delivering the myocardium. So if this is my myocardium, these are the capillaries that drive in from the epicardium all the way to the endocardium. And when the left ventricle is in contraction, you have limited blood flow. So blood flow is much more significant to the myocardial tissue itself from the coronary arteries during diastole, which means that coronary arterial circulation requires a diastolic pressure of greater than 40 or 45 millimeters of mercury in order to drive perfusion to the myocardium during diastole. Oh my God, don't let diastolic pressure drop below 45, because when you do, the coronary arteries may collapse. You may then see, all of a sudden now my patient's got VTAC. He has VTAC because he has tissues that are hypoxic because he couldn't deliver blood flow through those coronary arteries. Gotta have a diastolic pressure of 45 or greater. We say 40, 45, let's just be safe, 45 or greater. That's what's going to help us to actually drive coronary arterial perfusion. The LV has a very high demand for oxygen because it's always in hemodynamic stress when contracting. Always, and it's highly at risk for an imbalance of oxygen supply through the coronary arteries and oxygen demand at the myocardium itself. The left heart fills, remember, from a low venous pressure system. That low venous pressure is, of course, a reflection of the conduit of blood flow through the pulmonary vault powered by the right ventricle. Right ventricular power ultimately fills the left ventricle. So we think about left ventricular pressure. Left ventricular diastolic pressure is 0 to 4. Left atrial pressure is 4 to 8. Pulmonary arterial occlusion pressure or pulmonary capillary wedge pressure is 8 to 12. And pulmonary artery diastolic pressure is typically 8 to 15. That means this is the pressure gradient that must be overcome by the pulmonary vascular tone in order to promote filling of the left ventricle. So let's remember that the left ventricle is a really thick wall and it has a very lateral surface that is also a free wall. So very important. It means the lateral surface really isn't suspended to any vessels particularly. It's a much less distendable chamber because it's less compliant. And that any loss of compliance in the ventricular muscle requires an increase in the pressure required to fill the ventricle, which means the right heart better be able to work harder to mobilize blood flow to the stiff left ventricle. And typically the right heart doesn't accommodate very well. So what that actually means is now I have volume engorgement in the pulmonary veins, which then promotes itself into pulmonary interstitial fluid, which we call pulmonary edema. Remind yourselves that the left ventricle is a work pump. It has low compliance and high pressure. It actually, if there is failure, you'll have an increase in your pulmonary pressures and a fluid flux into the pulmonary interstitium. Now, left heart ejects, let's remember, into the systemic aorta representing the arterial bed. So the left ventricle must generate a pressure that is high enough to actually open the aortic valve and bolus blood into the aorta. Okay, well, you've got to be a strong chamber to do that. So typically on systole, the left ventricle has to generate a pressure higher than whatever you're measuring as systolic pressure. So if systolic pressure is 100, the left ventricle really only has to generate pressure just a little above 100 to open the valve and bolus the blood flow out. If your systolic pressure is 210, your left ventricle has to generate pressure greater than 210 to open the aortic valve and bolus the blood out. Now that actually doesn't take a PhD in physiology to understand that the amount of work to generate a pressure of 100 is much less than the amount of work to generate a pressure of 220. And that's, of course, why hypertension is so disastrous to the ventricle. Because when you have a loss of vascular tone, or you have significant enhancement, actually, of vascular tone, as you would with hypertension, that means your ventricle has to work so much harder to bolus blood out into the artery. So we don't like that. We don't want that. And we want to remind ourselves, if the ventricle is working hard to bolus blood out, it's also going to become non-compliant. Once it becomes non-compliant, you're going to start to have engorgement in your veins. And that's, in this case, with the left heart, that would be poor blood flow forward, engorgement backwards, and pulmonary edema. Pretty straightforward. So now let's look at this constant visualization. So we're very fortunate on this cartoon that what you're seeing first is LV systolic, which is 120, and LV diastolic, which is 0. And the LV ejection boluses blood into the systemic artery, transporting oxygenated blood. And in the middle of that systemic pressure, you see a thick red line. That thick red line is the mean pressure. The farther you get from the heart, the lower the mean pressure is. The end result of the mean pressure is to drive blood flow through the capillaries and push the venous column of blood back to the right atria and therefore the right ventricle. So mean pressure drives perfusion through the capillary and pushes the blood back to the ultimate filling chamber for the left heart. The filling chamber ultimately at the end of its cycle is the right atria or the right ventricle. So very, very important for us to remember that if I lose right ventricular compliance and my filling pressure, venous pressure goes up, that means I have a burden to the left heart in order to generate enough pressure in order to overcome that resistant venous column, which is one of the ways that we look at forward failure. Meaning I have failure of the left heart and then I ultimately have failure of the right heart, and now I can't move blood flow forward. It's also backward failure. When I have failure of the right heart and a venous column and a venous pressure that goes up, it causes a failure of the left heart because now the left heart has to work so hard to mobilize its blood flow. Now this is a simplified way of explaining diastolic and systolic dysfunction and forward and backward failure. It's very simplified. I'm not saying it's quite that simple, but the theoretic underpinning is actually that simple. Okay, so if we talk about shared circulations, from the left heart via left ventricular stroke volume, we mobilize blood flow into the arteries, and that actually gives us systemic arterial pressure. The vascular tone gives us systemic diastolic pressure, and a calculated mean which determines the pressure of perfusion and delivery of oxygen at the cellular level. Now that blood flow is returned back to the right heart, and it's directly affected by RV function, by the filling of the RV, and by RV ejection, RV stroke volume. Now let's talk about the right heart. The right heart demands for oxygen. The right ventricle is a very thin wall. It's a very non-muscular. It's a lazy ventricle, just conduiting blood flow by very simple strategies up into the pulmonary vault. The RV myocardium, because it doesn't have to develop such tension on contraction, it actually is perfused both on systole and diastole. And RV oxygen demand and extraction, the utilization of myocardial oxygen, is higher whenever there is hemodynamic stress, but because the muscle wall is less dense and less hypercontractile, it's somewhat limited in terms of oxygen requirements in hemodynamic stress. The right heart fills from the systemic veins, and it's a very thin lateral free wall. It's supplied primarily by the right coronary artery and the left anterior descending coronary artery. It's a volume load dependent. So it's often referred to not as a contractile pump like the left ventricle, not as a pressure pump like the left ventricle, but as a volume pump. And it basically just is transducing volume from central vein to right atria to right ventricle up into the pulmonary artery. So in a nice normal state, the pressure that is generated when the ventricle is filled, known as the CVP or the right atrial pressure, really low, very close to zero. And remember, typically those pressures don't go up because of volume. They go up because of failure of compliance. So that's a really important distinction when we talk about central venous pressure monitoring, when we talk about pulmonary artery pressure monitoring. It's really incredibly important to understand that pressure is about volume over change in compliance. You're going to hear that a lot, especially as we talk about ventilation. Pressure over change in compliance. Now the right ventricle, remember, is it doesn't have to generate such significant pressure. It has to overcome the resistant pressure in the pulmonary artery, and to mobilize that blood forward, that's typically around 20 to 30 millimeters of mercury, unlike the left heart. Now, if I have pulmonary hypertension, I have loss of vascular tone, I have a chronic fibrous disorder, that pulmonary pressure is going to go up, and that's going to put an extraordinary burden on the right heart. Okay, so the most important thing is that the pressure at the beginning of the PA must overcome the resistance of left atrial and therefore left ventricular filling. But here's the most important thing to remember about the right heart, because I think the right heart is sort of the Cinderella stepchild in critical care. Most people do not pay much attention to right heart function. The right heart is very, very sensitive in changes to pulmonary afterload. Now, pulmonary afterload means I have vascular changes in my pulmonary vessel, making that pulmonary pressure higher and requiring the right heart to eject against it. So those are chronic pulmonary hypertensive patients. We usually know about them when they come to us. But what we don't always think about is the introduction of positive pressure ventilation and the extraordinary burden that puts on the right heart. Now, especially in COVID-19 patients, but really in all ARDS patients or any patients who are intubated on a ventilator, we always have to consider that positive pressure that we deliver into the alveoli actually compresses the pulmonary vasculature. And as we compress the pulmonary capillaries primarily, what we start to see is the pulmonary pressure goes up. As the pulmonary pressure goes up, the right heart has to work harder to move blood flow into the pulmonary artery. And hence the reason that frequently, and especially in critical COVID-19 patients, we think about pulmonary vasodilation, utilizing Velitrate, Flolan, eprosenil, nitric oxide. So most particularly, we see the cheaper, pretty robust form of pulmonary dilation, which is inhaled Flolan, which is basically Velitrate, it's just a different name, which is a pulmonary vasodilator. Now we do that because the extraordinary burden we put on the right heart with our ventilatory support has to be overcome by the right ventricle. And so what we try to do is dilate your pulmonary vessels to make it easier for your right ventricle to bolus blood into the pulmonary artery. Remember that our subjective evaluation is our patient's neck veins are distended, their systemic veins are distended, they have a lot of interstitial edema. They did come into the hospital weighing 62 kilos and now they weigh 80 kilos. And by the way, they are not enjoying pizza and Ben & Jerry's ice cream. They have a fluid overload that has caused them to gain weight. And along with that, they now have renal dysfunction. Now we're trying to remove volume, but the real problem is that the right ventricle was not able to mobilize volume through the pulmonary vault. They aren't really volume overloaded. They are veno volume overloaded, but they're hypotensive and they have poor blood flow dynamic. So they're veno volume overloaded and arterial volume underloaded. Very important in terms of how we look at our patients. Now, we don't actually see the right ventricular pressure here in this cartoon, and I have to apologize for that. These are my cartoons, so sorry about that. But what we're seeing is from the initiation of the pulmonary pressure into the pulmonary capillary and ultimately filling the left ventricle through the left atria. So what we want to remind ourselves as well is that the right ventricle has to bolus that blood into the pulmonary artery at a pressure that is enabled to overcome the filling pressure of the left ventricle. And that's what you're looking at here, right? And remember that here we're looking at that thick blue line that indicates the pulmonary mean pressure, and the pulmonary mean pressure overcomes the resistance of left-sided filling. Now, when we think about right to left circulation, remember that right ventricular function is about mobilizing blood flow through the pulmonary vault so that blood in its capillary has exposure to gas exchange at the alveolar capillary interface. That means in order to optimize oxygen uptake into the blood and CO2 download into the alveoli, you must have a good blood flow dynamic. And that's incredibly important. Once that blood becomes oxygenated, it now gets returned to the left atria and then the left ventricle in order to get prepared for ejection into the systemic artery. So, reminding ourselves about making these measures. Same principles, but different values, right? We look at right ventricular filling pressure as CVP. We look at left ventricular filling pressure generally as pulmonary capillary wedge or pulmonary artery occlusion pressure and PAD. So the right-sided filling pressure is lower than the left-sided filling pressure because the right ventricle is more or less compliant than the left ventricle. Correct. The right ventricle is more compliant, so the pressure is lower. The pressure in the left ventricle is higher because the left ventricle is not as compliant. And so right ventricular pressure is lower than left ventricular filling pressure, pressure required to fill. And very, very important to remind ourselves that in normal relationships, the right and left ventricle share a lot of similarity. So the blood flowing from right ventricle to left ventricle and left ventricle back to the right ventricle is primarily dependent on ventricular function. But I do wish to say, when you have left ventricular dysfunction, we almost always know that. You had an echo, you've got an EF of 15%. Remember, EF is stroke volume divided by end diastolic volume, or the volume filling the ventricle. You're only ejecting 50% of that volume. You've got a lot of volume left in the left ventricle. It engorges the pulmonary vein. You end up with pulmonary edema. We love, love, love to look at that left ventricle and blame everything on it. But the actual truth of the matter is, and in particular in critically ill patients with positive pressure ventilation, we understand that using certain strategies in mechanical ventilation will actually put your right ventricle significantly at risk. And depressed right ventricular dysfunction is linked to a much more severely compromised left ventricle. So I want to keep my eyes wide open to evaluate right and left ventricular dysfunction in the critically ill population to try to determine what is necessary. Now remember, we talked about right versus left ventricular resistance and resistance in the artery. We actually do a small calculation for this. That's called the afterload calculation. Afterload is a calculation that looks at the amount of pressure at the beginning of the circuit to the end of the circuit. So for the left ventricle, MAP, mean pressure at the beginning, to CVP, pressure at the end, divided by cardiac output. That gives us a calculation called systemic vascular resistance. It's a pure calculation. And for the right heart, it's from the mean PA to the wedge pressure divided by the cardiac output. So we get a very low resistance calculation. The high resistance calculation, known as SVR, is normally 800 to 1200 dynes per second to the third power. And the low resistance calculation, known as pulmonary vascular resistance, typically is less than 200 dynes per second to centimeter to the third power. So we talk a lot about afterload. Afterload, meaning how hard does the right heart have to work to bolus blood? And afterload, meaning how high does the left heart have to work to bolus blood? What's most important is to remember that the right ventricle boluses blood against a low resistance system. When you make that resistant high resistance for the right ventricle goes into failure. The left ventricle is used to a high resistance, but the higher the resistance, the more oxygen the ventricle must consume and the more at risk the ventricle is. When the resistance is too low for the left ventricle, then the left ventricle doesn't generate enough tension or work in order to mobilize blood flow forward into that low resistance circulation. And then, of course, reminding ourselves about the difference between the right and the left ventricle in terms of ejection fraction. Right ventricular ejection fraction, normally 40 to 50%. Left ventricular ejection fraction, 50 to 75%. Different ejection fractions, different filling pressure, different tension required, afterload, and different ejection fractions between the right and the left heart. So we always want to remind ourselves about the difference in filling and ejection, in tension and in work, and in the ejection fraction that is measured of both the right ventricle and the left ventricle. This gives us tremendous insight, even if we don't have any methodology to monitor the pressures that are generated, just tremendous insight into evaluating when someone's urine output is going down and their pulmonary bed is getting wet. That problem is about the left ventricle. And when they become more hypoxic, but the lungs are dry and the central veins are getting wet, that tells us about the right ventricle, even if we're not monitoring invasive hemodynamics. So that brings us back to the understanding of a double circuit system. The double circuit being both deoxygenated and reoxygenated blood flow. And it's also the arteries for either side of our heart. Pulmonary artery for right ventricle, systemic artery for left ventricle. And the venous columns, which ultimately fill the ventricle. Systemic vein for the right ventricle, and pulmonary veins for the left ventricle. Understanding that there are 4 systems that we have to evaluate when we want to understand the dynamics of cardiac function and the mobilization of blood flow. We have to think about 4 systems. The deoxygenated system, which is motorized and mobilized by the right heart, both filling and ejection, which is deoxygenated, right heart. And the left heart, both filling and ejection, which is reoxygenated and mobilized by the left heart. They are not the same. It does our patients a disservice to assume that they're the same, but we always want to remember that one cascades into an effect on the other. So that brings us to basic caveats in pressure monitoring. Okay? LV dysfunction will induce RV dysfunction. But RV dysfunction also induces LV dysfunction. And any increase in pulmonary pressure will induce RV dysfunction. So that can be the long-term chronic pulmonary hypertensive patient. That could be from the short-term acute pulmonary embolism and from the iatrogenic application of positive pressure in the thoracic vault that now requires right ventricular function to overcome it. So most important for us to remember is that we don't want to assume that right and left are the same. They are basically the same in a very stable, healthy population. But we must remind ourselves that any acute changes that occur in right ventricular or left ventricular function will significantly and profoundly affect this very delicate, synergistic balance. So we must remind ourselves that the major function of the cardiovascular system is to supply sufficient amounts of oxygen to meet the metabolic demands of the heart, of the tissues, and that the primary contributor to oxygen delivery in the cellular capillary interface is cardiac function. Right heart measures do not always reflect what the left heart is doing, and right-sided filling pressures are about the pressure column of filling the right ventricle. That does not necessarily correlate to the pressure column filling the left ventricle. Right heart measures and right heart pressures are a separate entity. Only in the healthy population do right heart measures reflect left heart, and that may very profoundly mislead you in abnormal circumstances. So we always want to remind ourselves that everything that has to do with pressure is most significantly about changes in compliance. That's every pressure you measure: intra-abdominal, intracranial, intrathoracic, intrapulmonary, intraalveolar, intracardiac, intravenous. These are all indicators of volume over the change in compliance. And by the way, the greatest of these is the change in compliance. So we always want to remind ourselves that measures that you try to make fit volume, they require a thoughtful process to actually assure that there isn't a change in compliance. I urge you to go to education.edwards.com/ICU #Hemodynamics. That's a mouthful. You can just go to Education Edwards and navigate from there. But if you get to this level, there's a sidebar with hemodynamics. You'll see 6 slide, probably more than 6 slide programs on hemodynamics. There are 6 done by me, and then 2 or 3 done by others. And those slide programs, which may also be correlated with an audio description, will help you uncover hemodynamics. The other thing you can do, especially because you're coming to the ICU, is in the body of this, you can click on EV1000 or click on FlowTrack, and that will actually engage you in understanding the properties of the EV1000 monitor and the FlowTrack transducer. The EV1000 and the FlowTrack actually enable us to look at LV ejection through the stroke volume measured in the arterial bed. Thank you so much. And my question is always, are the right and left ventricle actually working together? Thank you.